Hello, Nighthawk Nation. This is Dr. H here, Health 3100. I want to go over a few chapters with you, chapters 10, 11, and 12, module 4. So chapter 10, which starts on in your text on page 172, Informatics for Health Professionals, Workflow and Meaningful Use. Uh, Informatics This chapter connects critical concepts in healthcare workflow with the evolution of the government incentive programs that have helped shape health information technology adoptions. Some of the things that you're going to learn or you should learn in this unit is how to provide an overview of the purpose of conducting workflow analysis and design, how to deliver specific instructions on workflow analysis and redesign techniques, and cite measures of efficiency and effectiveness that can be applied to redesign efforts. In an introduction to workflow in healthcare, workflow represents the sequence of physical and mental tasks performed by various individuals within and between work environments and healthcare. Such workflows are complex and variable at times, highly collaborative, information intensive, safety critical, subject to regulatory requirements, even. Understanding workflow is essential because health information technology, or HIT, fundamentally changes how health professionals accomplish their daily tasks, and sometimes for the better. You're going to want to make sure that you know some of the core workflow concepts. Healthcare workflow concepts consist of tasks, actors, tools, which are resources to complete tasks, such as EHR, mobile devices, what have you, time, and location. You'll want to know different workflow analysis methods. Several approaches can help us understand existing workflows: process mapping, time motion studies, value stream mapping, contextual inquiry, task analysis, and role responsibility. Um, I'm going to take a look in your book real quick. I should have had it marked, but I didn't. On page 172, it'll go into a little more detail on what the workflow analysis purpose is. It'll discuss information systems, computer provided order entry or CPOE. And these are items that you definitely need to know. It'll discuss workflow and technology on page 175. Workflow transformation effects are going to be such things as task redistribution, new task creation, task elimination, removing previously necessary steps, sequence changes, communication pattern shifts, location independence. And there can be positive workflow impacts due to this workflow transformation. Well-designed technology can reduce redundant documentation. That's the whole purpose of EHR. Improve information availability, enhance clinical decision support, and standardize process for safety. It also can help facilitate care coordination. Now, some of the negative impacts, it can increase documentation burden if it's poorly implemented. It can create workarounds and shadow systems, fragment attention and increase interruptions, add unnecessary steps and complexity, and then disrupt team communication. Some of the meaningful uses and some of the evolutions to understand current health IT incentives, we'd have to review how we got there. And if you go back to the HITECH Act of 2009, which established Medicare and Medicaid EHR incentive programs with three aims, and I want you to know these three aims. It was to improve quality, safety, and efficiency of care, engage patients and families in their care, and improve care coordination, population health, and public health in an attempt to reduce health disparities. And we covered this in a module back, and it's really important that you know this. You have an assignment coming up where you're going to want to and need to know this information. And this is something you want to carry forward with you as you go into your professional career. The program was rolled out in progressive stages. Stage one took place from 2011 to 2012, and it was at this time that the anticipation of data capture and sharing took place. 2014, advanced clinical processes were introduced. And then in 2016 through today, improved outcomes are required. Each stage included specific objectives and measures for healthcare organizations needed to meet and receive incentive payments. And so it's a kind of a big thing. If you didn't meet these requirements, your financial incentives were taken away. Key meaningful use of in requirements. Core requirements included CPOE or computerized provider order entry, electronic prescribing, clinical decision support, patient portal access, something we take for advantage today, but it always hadn't been available to probably 90% of patients. Health information exchange. This is the importance of electronic health records. It can allow physicians and from hospital to hospital, from doctor's office to doctor's office, to not have redundant testing and treat a patient more efficiently and effectively. Security risk analysts and clinical quality measures. So optimizing the workflow with health information technology. There's several approaches that can be used to improve workflow. User-centered design principles, which involve end users throughout development, map current and design future workflows, design for actual work environment, test with realistic scenarios, and iterate based on user feedback, which is huge. Knowing what user feedback is and how it's affecting the patients and the stakeholders, such as doctors and nurses, the care providers, it's tremendous. There are continuous improvement approaches when it comes to health information technology, a regular workflow assessment, user feedback mechanisms, different ways to uh, conduct or receive that feedback, data analysis of system usage, small tests of change where maybe we change steps, eliminate steps, things of that nature in small increments to see how that's going to affect the overall usability and efficiency of the system. Formal process improvement methodologies. Some of the health information exchange models that you want to know, directed exchange or point-to-point, query-based exchange, and this is where we pull information as needed, and consumer meditated exchange, patient-controlled sharing, which is huge. The more we can get our patients involved, the better it's going to be for everyone involved. Future directions in workflow and technology. There's several trends that are shaping the future of healthcare workflows. Artificial intelligence or AI and automation are probably the biggest. Automated documentation through natural language processing, predictive analytics for workflow prioritization, intelligence triage and routing. The patient as a participant. Um, this cannot be underestimated. Patient-generated health data integration, self-scheduling and registration, remote monitoring, shared decision-making tools where we involve the patient in their healthcare. It's no longer a patient going to the doctor and the doctor telling the patient what they're going to do. That patient is actually a part of the process, and that it's shown huge dividends in overall healthcare. We can look at team-based care models such as care coordination platforms, collaborative documentation approaches, um, virtual team collaboration tools, Zoom, Skype, Teams, things of that nature. Workflow and technology are inseparably linked in modern healthcare. While programs like Meaningful Use accelerate adoption, attention must now focus on optimizing systems to truly support clinical work rather than adding them as a burden. As health professionals, you have the ability to contribute by actively participating in workflow analysis and redesign, providing specific feedback on technology impacts, suggesting improvements based on your clinical experience, and advocating for technology that truly serves patient care needs, which at the end of the day, that is what we're looking for. And that's everything from chapter 10. Chapter 11, which picks up on page 192, informatics for health professionals, the electronic health record and clinical informatics. Um, and this is a more in-depth introduction to healthcare records. The electronic health record represents the digital version of a patient's medical history. It's designed to replace paper-based records, provide real-time patient-centered information, support care coordination across different providers. Um, so just kind of give you an idea of what we're looking at. Some of the things that you should learn when coming out of chapter 11, and it's right here on your book. Um, Describe the common components of the electronic healthcare record, assess the benefits of implementing electronic health records, explore the ownership of an electronic health record. Chapter 11, right here. Okay. Also, when you look on your PowerPoints and you look on your course objectives, you'll see additional items that you should take away from this. Now, keep in mind the evolution of EHR has come a long way. The early systems, somewhere between the 60s and 80s, 1960s, 1980s, were mainframe-based hospital information systems that focused on administrative and billing functions. They had limited clinical capabilities, and they were restricted to large academic and medical centers for the most part. The transition period that really took place to what we know it a little more today took sort of began in around the 1990s to the early 2000s. And it was then when we started seeing client server architectures, expanded clinical documentation, introduction of basic order entry, and integration of laboratory and pharmacy systems. And then the EHR as we know it today, sometime in the 2010s, 2013, right in that range, we began to see web and cloud-based platforms, comprehensive clinical functionality, mobile and tablet interfaces, which have been tremendous, integrative decision port, population health capabilities, and patient engagement features such as wearable devices. Some of the core each EHR components. Uh, Modern EHR systems include several essential components such as clinical documentation, computerized provider order entry, CPOE. This is where medication orders with safety checks, laboratory and diagnostic tests ordering sets of common scenarios, electronic signature capability. So the CPOE really opened a lot of doors to help us with the efficiency of healthcare. We're able to look at results management a little deeper. We're able to see the laboratory result review and the trends. We're able to look at diagnostic imaging reports and images a lot faster than what we ever could before instead of waiting for a report to come back. Consultant reports and recommendations, abnormal results highlighting, and results acknowledged tracking. A lot of this will come back to clinical decision support, or better known as CDS. And you're going to find this in your book. Maybe I can tell you, maybe not. Around page 196. So, and some of the things to think about with CDS, drug-to-drug interaction alerts, allergy warnings, evidence-based order sets, care gap reminders and alerts, and diagnostic assistance tools. This has really helped us or helped us to eliminate some drug interactions in which maybe a patient is seeing an orthopedist and then also their care provider. And so they're taking medications from both. And now these care providers can look and see what medications that individual is taking to make sure that two medications aren't going to interact in a negative manner. And so this has come a long way. Health information exchange, the interoperability with other providers. This is what we just talked about. Document exchange capabilities, data reconciliation tools, and recognition and national network connections. So no matter where you go in the country, you have access to your medical records. A doctor has access to your medical records. We've seen several patient engagement features, such as patient portals, secure messaging with providers, allowing patients to have conversations with their providers without actually having to go in. And not only does this save the patient time, but it also allows providers to spend more time with the patients in their office while still providing care with patients outside the office. Um, EHR implementation and considerations. Organizational readiness. We have to look at leadership commitment and vision when it comes to EHR. The infrastructure assessment. Is there an infrastructure in place? There should be at this point, but you never know. Cultural readiness for change. There are going to be people who still want to put everything in writing on physical documents. And we know with EHR, the efficiency and the security for the patients, um, that is something we have to look at when we think about cultural readiness. Staffing and support planning. We have to make sure that we have the staffing and the support available to put all the information in to the system for the electronic health records. Some of the implementation approaches, Big Bang, which is simultaneous implementations across the organization, or phase, which is a gradual rollout by department or functionality. Parallel, running old and new systems simultaneously, or a pilot, testing limited areas before full deployment. Some of the safety benefits of EHR, legible documentation, automated alerts for errors, clinical decision support tools. And as with everything, there's always some safety risk. Alert fatigue tends to be a big one. Um, the- we see so many alerts, we stop seeing them, and we have to make sure we can mitigate that. Copy and paste documentation errors. It doesn't take much for there to be you have a small error one place, you copy and paste, you put that somewhere else, and I believe we talked about this on one of the assignments, and the errors that that can create. User interface designer flaws and information overload and cognitive burden. These are some of the big safety risks when it comes to inputting into EHR. Um, let's see, let's talk about measuring success. Some of the key metrics to evaluate EHR effectiveness include user satisfaction scores. Every doctor's office, every hospital, or they look at patient feedback and user satisfaction, alert override percentages, and quality measurement performance. So these are just a few of the things that we're looking at with that. EHR and healthcare analytics. EHR serves as a primary data source for analytics. Some of the levels of healthcare analytics, we have descriptive, which explains what happened. Diagnostic, why did it happen? Predictive, what will happen? And prescriptive, what should we do? And these are the four levels of healthcare analytics that you definitely need to know. And I want you to remember and see how you could apply these in different situations. There's some case studies in your book. Go in and look at your book and see if these would apply in those situations. Some challenges in EHR analytics, data standardization issues, missing or incomplete data, which can skew your results. Integration of multiple data sources. So if we have multiple data sources and they're using different coding, this can cause issues. There's always a privacy and security concern. We never want our patient information getting out. And then distinguishing correlation from causation. Um, and this, you'll want to make sure that you understand the difference, correlation from causation. That is going to be a test question, and it is something that you will need to take with you moving forward in your professional career. Um, EHRs and care models. Some we look at patient-centered medical homes. EHRs enable core PCMH functions such as comprehensive care documentation, care coordinates, population management, patient engagement features, things of this nature. There's definitely a value-based care. When we look at EHR system support, we're looking at quality measuring, tracking, cost and utilization, risk stratification tools, care gap, virtual care integration as well is something that we'll look at with EHR. Modern EHRs increasingly incorporate telehealth visit documentation, remote monitoring, asynchronous communication tools, digital care management, and virtual care workflow support. Some of the future directions that we can see with EHRs, and you'll see this actually in your book on page 204 and 205. Open APIs in APP ecosystems, SMART or FHIR framework, third-party application integration, user-selected functionality. We'll definitely, and we are seeing AI integration to assist with image recognition for diagnostics, workflow optimization through process mining, personal care recommendations. And then there's also patient-generated health data. This is going to be such things as wearable devices, home monitoring, patient-reported outcomes. And this is a huge direction and probably one of the biggest benefits of EHR and clinical informatics. So now we are moving on to chapter 12, which is page 209 in your book. Some of the things that you should take away from chapter 12 is you should be able to explore the characteristics of a safety culture, examine strategies for developing a safety culture, recognize how human factors contribute to errors, and appreciate the impact of informatics technology on patients' safety. Healthcare professionals have an ethical duty to ensure patient safety and privacy and security. This is number one. Increasing demands on professionals is complex in a fast-paced healthcare environment. We have to make sure that we're not cutting corners or developing workarounds, that deviations are more often practiced in the interest of saving time or because the organizational culture is such that risky behaviors are commonplace, or these deviations as far as cutting corners. Occasionally, inappropriate actions or omissions of appropriate actions result in harm or significant risk of harm to the patients, which is absolutely the last thing we want in the healthcare industry. This is a sentinel event. A sentinel event is a patient safety issue that results in death, permanent harm, or serious temporary harm requiring intervention, and is termed as a sentinel event by the Joint Commission in 2017. You want to make sure that you go through and look at your safety initiatives. You will find these uh, somewhere in your book. You'll find these on pages 217 through 221. And your safety initiatives, such as the 2002 Joint Commission on National Patient Safety Goals, you'll want to make sure you know this. The 2004 World Health Organization Alliance for Patient Safety, the 2008 No Pay for Errors Medicare Initiative, the 2016 National Patient Safety Goals. Some of the key features of a safety culture is the acknowledgement of high-risk nature of an organization's activities and the determination to achieve consistency, safe operations, encouragement of collaboration across ranks and disciplines to seek solutions to patient safety outcomes. Um, what is a just culture? This is something else you're going to want to know. It's a blame-free environment to encourage error reporting. If we don't encourage error reporting, we could very easily have a sentinel event with one of our patients, and that is the last thing we want. We are looking to improve healthcare. We want to make sure there's a clear message that is communicated when reckless behaviors are not tolerated. Reckless behaviors, no matter who is it's done by, cannot be tolerated when it comes to patient safety and care. Just culture error types, human error, unintentional mistakes, risky behaviors, which would be from workarounds or cutting corners, and then reckless behavior, a total disregard for established policies and procedures. We want to make sure that we're promoting a safety culture. AHRQ suggests that teamwork training, executive walkarounds, and unit-based safety teams have improved safety culture perceptions, but have not demonstrated a significant reduction in errors. IHI strategies include appointing a safety champion for every unit, creating an adverse event response team, and reenacting or simulating adverse events to better understand the organizational procedural processes that failed. Um, Doing these dress rehearsals, if you will, goes a long way. So when a problem does actually occur with a real patient, we know how to approach it, we know how to correct it, um, and we know how to keep it from happening again. Some of the human factors, the discipline of applying what is known about human capabilities and limitations to the design of products, processes, systems, and work environments. Its application system design improves ease of use, system performance, reliability, and user satisfaction while reducing operational errors, operator stress, and training, user fatigue, and product liability. This was a statement written by Eben et al. In 2008 concerning informatics and action planning. Information chaos. This is something else that takes place a lot of times, or it can take place if we don't have proper procedures in place, such as information overload. And this is where we're receiving too much information that's not needed. Information underload, where we're missing key pieces of information from our patients that was not put in by the provider or asked for. Information scattered, and this is information located in several places, making it difficult to find. And that's why we want to stay streamlined. We want to stay efficient. Alarm fatigue, and we spoke about this a little bit in chapter 11. Medical equipment alarms frequently and inappropriately may be related to the sensitive alarm parameters. Some strategies to improve alarm response: improve the patient call system by adding voice over internet protocol or VoIP. Feeding alarm data in a reporting database for further analysis. further analysis. So we want to take, whenever an alarm goes off, we want to put that into a system. And so we can further analyze that and encourage healthcare professionals to round with physicians to provide input with alarm parameters. So we're not just sitting there at a desk or in a cubicle, we're actually making rounds with professionals so we can discuss and find out what the alarm parameters are and how we can input this. Um, some of the most frequent safety issues, wrong site surgery, hospital acquired infections, falls, hospital readmissions, diagnostic errors, medication errors. Many of these issues can be prevented or detected using informatic technologies and following strict guidelines set forth by the information that we put into our analysis systems, our data analysis. Technologies to support the medication administration cycle, assessment of need, ordering, dispensing, distribution, administration, and evaluation are just some of the medication administration cycles. You'll want to know this as well. This is going to be towards page 226 in your book. Five rights of medication administration. We want to make sure we have the right patient, the right time and frequency of administration, the right dosage, the right route, and the right drug. This sounds simple, but um, these small errors can result in uh, a real negative event happening with our patient. And this is one of the things that we want to make sure does not happen. Let's talk about just real quick computerized physician order entry or CPOE, some of the benefits. Prompts warn against the possibility of drug interaction, allergy, or overdose. So we know that if we have two different medications that interact in a negative manner, we'll receive an alert on that. Accurate current information that helps physicians keep up with new drugs as they are introduced to the market. Drug-specific information that eliminates confusion among drug names that sound alike. There are a lot of drugs in the industry that sound very similar but do very different things, and so CPOE definitely helps keep that negative from happening. Improve communication between the physicians and the pharmacists. This is to help make sure that the patients are getting what they're supposed to be getting, and if there's a question of why, the physician and the pharmacist could get together and sort this out. Reduce healthcare costs due to improved efficiencies. And so by being more efficient with this CPOE, it's allowed it's helped to bring healthcare costs down and bring efficiency up as well as health disparities down. Barcode medication administration, or BCMA, is something else that you're going to want to make sure you understand. It provides a system of checks and balances to ensure medication safety. Barcodes on the patient's ID bracelet is scanned, prompting the electronic system to pull up the medication orders. A barcode on each of the medications is to be administered is scanned, and the technology checks to ensure that the five rights of medication administration, right patient, right med, right dose, right route, right time are met. Um, CDS or clinical decision support. We've talked a little bit about this in chapter 11, and then you're going to discuss it again in chapter 12. CDS picks up on page 217, and it's covered for approximately 3 to 4 pages. That's the importance of clinical decision support, or CDS. This helps a clinician select an appropriate medication, provides double checks for interactions, assists with infusion pump programming, checks for interactions with foods, provides patient education and guidelines. So the importance cannot be understated of CDS. Um, let's talk about RFID. You're going to have several questions about RFID on an upcoming exam, and it's also going to be in an assignment, and it's going to be something that you work with in your professional environment. Expanded RFID uses helps patient tracking during procedures and testing, helps to track medical supplies, um, reduce the likelihood of wrong patient, wrong site surgical procedures. Specialized tags can detect temperature fluctuations and thus ensure that blood or blood product was stored at the optimum and secure site. This stands for radio frequency identification, RFID. Smart room technology. The RFID tag on an employee name baggage announces to the patient on a monitor exactly who has entered the room, triggering a need to know data by the caregiver. Smart room technology allows clinicians to review patient data in real time and alerts clinicians as they enter the room about procedures that need to be implemented for the patient. Um, Other than that, that is going to be everything for Module 4, covering chapters 10, 11, and 12. I know that's a lot, um, but it's a very important module. It's a very important unit. A lot of it you've learned in prior modules and prior units. If you have any questions, as always, reach out and let me know. Um, and my public safety announcement, my PSA, all quizzes and exams are due at noon. You should be probably halfway done with your group project by now. So if you have any questions with that, reach out and let me know or let the instructor of the course know. Um, Other than that, um, have a wonderful Nighthawk Nation day, and I look forward to seeing you again. Thanks, everybody. Bye bye.